So now I want to move to some other new data that I have in trying to understand the contribution of different injection practices to HCV seroconversion. There have been a lot of studies that have reported the relationship between receptive syringe sharing and HCV seroconversion. And you can see that the range of the odds ratios or the relative risk of infection varies, but it's pretty uniformly high and statistically significant. In the meta-analysis, we also calculated a summary odds ratio of approximately 2. So people who share syringes are about twofold more likely to acquire HCV than those who do not. We also did a meta-analysis looking at the contribution of drug preparation equipment sharing and HCV seroconversion. And that refers to studies that looked at cooker and the shared use of drug cookers or filtration cotton with or without rinse water sharing. And here you also see a uniform excess risk, and the range is between about, there was no effect shown in the Montreal study, principally because there was so much of HCV that was attributed to syringe sharing, but the risk goes all the way up to a 5-fold greater risk in the New Zealand study. And so the summary odds ratio, or the summary risk, is that there's about a 125% excess risk of seroconversion associated with drug preparation equipment sharing. So we've all heard that, but now I want to put it into a slightly different context, which is to really look at to what extent can we attribute HCV seroconversion in what proportion of infections in injection drug users are really due to the sharing that particular injection practice. So there have been a lot of questions that have been raised, whether it's really a bias in our measures, that people are underreporting syringe sharing in these studies because of stigma surrounding syringe sharing. It's a socially undesirable behavior. And that as a result, we're attributing hepatitis C seroconversion to drug preparation equipment sharing when it really is due to syringe sharing. So we examined this relationship between seroconversion and injection risk behaviors that were measured using audio, computer-assisted self-administration of self-interviewing. And so it was not a face-to-face interview, but it was a person typing their answers into a computer. So this methodology is going to reduce this social desirability bias in our estimate of these various practices. So this is a study, it was a multi-site study in the United States of hepatitis C and HIV antibody negative young injection drug users under the age of 30. And we calculated hazards ratio, which is another type of a relative risk, to assess the association between risk behavior and HCV seroconversion. And we found that in the data that the shared use of cookers, cottons, and rinse water, those behaviors were very highly correlated. So we created a summary measure in this analysis to represent drug preparation equipment sharing. So here's the data. We recruited about 2,000 eligible injectors. Only 41% agreed to enroll in the study because it was a randomized control study of a behavioral intervention. So we lost a lot of people who weren't interested in attending our intervention sessions. But we did have about 320 person years of observation, and in that data we recorded 55 seroconversions, so the seroconversion rate was 17% overall. So this breaks down the risk of hepatitis C associated. It shows you the seroconversion rates in relation to each of these different factors. And the data that I'm showing here are based upon an adjusted model, a model that adjusts for all of these factors, which were shown to be we were focused, let me say this differently, we were specifically interested in estimating the risk associated with drug preparation equipment sharing. So we included other variables in the model which we felt were important to control for in coming up with an unbiased estimate of that risk. And so what you see is that injecting every day was associated with about a 2-fold excess risk of hepatitis C. Syringe sharing, this is interesting, okay? Syringe sharing was in a univariate analysis without adjustment. The odds ratio was 1.7, and it was not statistically significant. Syringe sharing may not necessarily be related to hepatitis C seroconversion in the context of syringe sharing where people are highly selective in who they share with. I mean, I think that this is not, I'm by no means advocating that as a prevention methodology, but I think that people are very much more careful about who they share syringes with versus who they might share other equipment with, and that's reflected in the data where we show that the risk associated with drug preparation equipment sharing was quite a bit higher. It was threefold higher in univariate analysis, and about 2.7 was the adjusted hazard ratio when we adjusted for other things. Backloading was also marginally related to seroconversion. So this is the point of showing you these data at this stage. Is we want to answer the question. How am I doing on time? Okay. I wanted to answer the question, what proportion of hepatitis C disease is due to the individual exposures? And this is, the formula for estimating this is the attributable risk, where you take the relative risk or the odds ratio or the hazard ratio or whatever you have, and you subtract one and then you divide it by itself. And then you multiply it times the proportion of seroconverters who practice that risk behavior. And I want you to appreciate that because that means that in any community, the degree to which this individual risk factors are present, that determines how important it is, of course, in the overall scheme of HCV seroconversion. So using this formula, we estimated that nearly 40% of HCV seroconversions in this very large multi-site study of young injecting drug users, that those were attributable to the shared use of drug preparation equipment. And I'm showing you how we came up with that estimate. And it's because about 60% of them, of the seroconverters, reported that in fact they did share drug preparation equipment. And again, this proportion, this attributable risk proportion, which is a very important epidemiological measure, it depends upon the prevalence of that particular risk factor in the community. And it tells you, if you were to remove that risk factor, the proportion of infections that you could prevent. As I mentioned, that syringe sharing has declined in a lot of communities where harm reduction services are available. But unfortunately, the sharing of other drug preparation equipment, it's gone down a little bit, but it still persists. And some of the rates, as you see here, 59%, that's relatively high. So even if syringe sharing if it can be brought to a very low level, HCV will continue to be transmitted. So my summary is that, as I stated in the beginning, hepatitis C is hyperendemic in drug user populations throughout the world. 50 to 80% are antibody positive after injecting for only 5 years. There have been not modest declines in prevalence in developed countries. This initial years following onset of injection is a very high risk period, but there's no evidence of the type of rapid acquisition that was reported in the 1990s when some studies, some of these were from the United States, and more recently there have been some studies from China as well that have shown very rapid acquisition just within the first 12 months of up to 80% being positive. We're not seeing that in a more recent era. The prevalence that we're seeing in developing and transitional countries resembles that was observed in an earlier era in industrialized nations. And because harm reduction programs expanded in 1995, and that coincides with this decline, that suggests that those indeed have slowed transmission. But again, we have not achieved control of hepatitis C infection. Harm reduction programs, the focus has been, I think, on HIV prevention and thereby on syringe access. We see, just based on looking around at the tables outside this room, that there's a greater focus now on drug preparation equipment. But I think we need to do a lot more in terms of education to fully realize HCV control and prevention in this population. That's the end. Thank you very much.